Welcome to Smart Women Talk. This is your host, Katana Abbott. I'm a midlife millionaire coach and a certified financial planner, and I search the world for smart women and a few good men, including best-selling authors and thought leaders who are on that leading edge. So join us for conversations on money, business, health, and inspiration, so you can live with more purpose, passion, and prosperity. Hi, everyone. This is Katana Abbott, and I want to welcome you all to Smart Women Talk. Today, I'm speaking with Dr. Dennis Holmes, the internationally renowned breast cancer surgeon, about cryoablation, or actually freezing the tumor for women with breast cancer. I just had this procedure myself last month, and I feel so honored and excited that Dr. Holmes has agreed to share his wisdom with us today. We're going to be talking about what cryoablation is, how cryoablation can be used to treat breast cancer, and who's eligible for cryoablation. So with that short introduction, Doctor, I'm so excited you're here. Thank you so much again for coming to Smart Women Talk and to share your wisdom with our Smart Women community.
I'm delighted to be here. It's really a great opportunity to talk about something that most women should know about. Hopefully, very few women will actually need, but for those who do need it, I'd like cryoablation to be one of the things that they can consider if they're diagnosed with breast cancer.
Yes, and it's right. It's not very well known out there, but could you tell us, please, a little bit about your journey?
The seed was planted about 20 years ago when I was a trainee. I attended a meeting where cryoablation was presented as a potential solution for treating benign breast tumors. It had not been used at that point for treating cancer of the breast, but I recognized it as a future treatment that I wanted to learn and master so that I could begin to offer it to women and be part of one of the pioneers of this technique. I first learned about it in 2002 and 2004. I started to practice it and also train others how to do it. In 2009, I joined the first U.S. multicenter trial looking at cryoablation for treating breast cancer. In that trial, the cancers were frozen but then removed. So it was a ablate and then excise trial. And then it was immediately followed by another trial, which I launched, in which we would use cryoablation as a way to treat breast cancers without subsequent removal. And I traveled to Japan to learn their experience, since they were a few years ahead of us here in the US. And since then, I have innovated a number of other applications for treating small breast cancers, as well as treating larger breast cancers, which are generally not considered appropriate for cryoablation. But the real reason for my initial interest and for continuing this is that as a trainee, I learned very early on that many women were not comfortable with the standard options that were being offered to treat breast cancer, the typical lumpectomy or mastectomy. They had a variety of reasons that some people were not quite comfortable with that. But I recognize that, number one, we need to listen to patients, and number two, have more options to offer patients so that they have treatment options that match their sensibility about how they want to be treated. And cryoablation was a perfect solution because it doesn't require surgery. It has minimal cosmetic effects on the breast. Often patients can avoid radiation. And so many of the things that sort of scare people away from the treatment can be avoided with the use of cryoablation. So it was just part of that patient-centered approach of listening to patients and offer them solutions that were more acceptable to them.
I was one of those people. I had the bad news that my mammogram had a calcification, but she said something to me that kind of set me off when she said, you have to come back and have another mammography. And if it's cancer, we're going to put you in our system. And I thought, I don't want to be in a system. And I've always been into nutrition, and I wanted to do something holistic. And so I came back and I did have cancer, and I had invasive ductal and I had DCIS, but it was super early, very small. And I asked them, if I don't get that, what is my option? And they didn't say cryoablation. They said mastectomy. And that's all they offered. And I thanked them. I was still so grateful because they had found this out. I'm so grateful to find out. I had been going there regularly. But that led me to finding Laura Ross's book. They're mine and I'm keeping them. And she actually referred me to you. Now, you didn't do my surgery. I ended up finally, after many months and meeting with different doctors, I finally found my team, the same team that she went to 20 years ago. But I'm just so grateful. But for me, I kept being told I wasn't a candidate, but because I refused surgery, they were able to actually help me here in Detroit, where I finally ended up getting the cryoablation. And I'm just so grateful. But not very many women know about it. Can you tell us a little bit about what it is and why it's not more well known right now? Because I don't think it's not approved by the FDA yet.
Correct. It's a work in progress, but cryoablation or tumor freezing is a way of treating the tumor by freezing the tumor and the surrounding tissue to a temperature that's cold enough to kill it. And so we're basically utilizing cryoablation as a substitute for lumpectomy instead of making an incision and excising or removing a tumor completely. We can freeze it in place, kill it, and allow the breast to heal naturally. What we can do with this approach is it can be done under local anesthetic, can be done through a tiny skin incision, just 2 or 3 millimeters. Since we're not removing tissue, we're not changing the shape or appearance of the breast contour is preserved. Since there's a minimal incision, there's less cosmetic effect on the breast. And of course, there's less changes in terms of sensation. There's less change in terms of the side effects that can happen, like fluid formation or bleeding that can happen as a side effect of surgery. So there are many advantages of doing the cryoablation procedure compared to surgery. For most people, if they've ever had the unfortunate experience of having a breast biopsy before, especially an ultrasound guided breast biopsy, it's very much like that experience. It's done in the office. The patient's positioned on her back. We use ultrasound to visualize the tumor. We make a small skin nick after injecting local anesthetic and simply insert a needle into the center of the tumor and freeze the tissue around the needle. The freezing takes place over a period of typically about 30 minutes. We freeze, we allow it to thaw, we freeze a second time. And after that treatment is completed, the needle is withdrawn, pressure is applied to the skin incision, and the patient is able to drive herself home without any significant burden to recovery. They can return to normal activities the very next day. We ask them to not exercise for the first 2 weeks using the upper body, but they can use their arms for normal activities. They can drive, they can work. So it really does allow someone to get back to their normal life quite quickly and have their breast cancer effectively treated in that 1 hour visit to the office.
It's simply amazing. And in my case, to make sure they got the whole area, because the original cancer wasn't there anymore for some reason. Either it went away or was taken out by the biopsy. They ended up doing 3 probes and doing 6 centimeters, even though the final spot was just 3 millimeters.
Yes, that makes sense. The secret, that that's not a secret. The art of cryoablation, I would say, is to have a well-visualized target. So if you have a well-seen target, say a nice round mass or a nice mass that you can see well by ultrasound, then you can accurately target it. And often it only will require 1 probe if it's a small enough tumor. But if the tumor is larger, or if the edges are a little less clear, or if you have some uncertainty about its location, then we have the liberty with cryoablation to treat a larger area. So you can freeze a much larger area without having the effects that you would have if you had removed the large area. There's no indentation or skin retraction or a hollow that forms in the breast after the procedure. It makes sense that if they were not quite certain of the location because the area was removed and because it was so tiny, so very small, it makes sense that they would treat a larger area just to have a wider safety margin around the original biopsy site.
Yeah, I was very grateful for that they're able to do that, because I know some procedures they can only use 1.
Right. In fact, the convention, most of the studies that were done to evaluate the effectiveness of cryoablation for treating breast cancers limited the treatment to patients with tumors that were singular, like a single mass, that was ultrasound visible and measured less than 2 centimeters. 2 centimeters was the maximum size that was permitted. And that was utilized partly because, first of all, most tumors meet those criteria. They're small, they're less than 2 centimeters, and they usually are singular. Number two, the ice ball that's created has a diameter that's approximately 3 centimeters maximum. And so you'd want to have a tumor that could fit well within that 3 centimeter diameter. 2 centimeter tumor would give you basically a 5 millimeter margin on either side. So it's the kind of the upper limit that we have generally used for treating with one probe. However, as we have the ability for some patients in some circumstances to use multiple probes. Instead of one circle that freezes, you can freeze a series of overlapping circles. And by doing so, you can expand the area that's treated from just a 2 centimeter tumor, so maybe a larger tumor treated with wide margins as well.
So let's talk about who qualifies.
Not everyone qualifies for any procedure. For cryoablation, though, there's the ideal patient based upon the tumor size and the ability of the tumor to be seen by ultrasound. The lowest hanging fruit, the easiest patients to treat, the most widely accepted population for cryoablation are women that are postmenopausal, that have tumors that are 2 centimeters or smaller, have tumors that are ultrasound visible, and tumors that are single, that is not multiple spots of disease, but one spot. And last part is that they have what's called invasive breast cancer, meaning breast cancer that is no longer confined to the milk duct. Those cancers tend to form masses that you can detect by mammogram or ultrasound. So stage 1, invasive breast cancers. The other criteria that are usually followed is that they have to have normal appearing lymph nodes, so no evidence of lymph node involvement. And generally speaking, they have to have estrogen receptor positive tumors. Stage 1, hormone receptor positive, node negative tumors, generally in postmenopausal women. That's the group that is most widely accepted. It's the group that has been looked at in most of the clinical trials that have been done. And it's the population that will most likely receive FDA approval for treatment with cryoablation because that's the group that's supported by the most data. However, we know from experiences using cryoablation in other parts of the body, like the liver or the lung or the kidney or the prostate, we know that it's technically possible to treat larger tumors and treat different kinds of tumors, particularly if we have the freedom to utilize multiple probes to treat a larger area. So although the classic patient that I mentioned is the one with the stage 1 estrogen receptor positive tumor that's ultrasound visible and single, I regularly treat patients with larger tumors, some with multiple tumors, even some with positive nodes, utilizing multiple probes to cover a larger area. Those patients are not necessarily the ideal patient, but often the women within that category may make a personal decision that surgery is not something that they want to consider. Or if mastectomy is the only surgical option that they're offered, maybe some decide that they'd rather consider another approach, cryoablation, as opposed to mastectomy as a way of preserving their breasts. So it's not the ideal group. It's not the group for which we have a large body of long-term data, but it is a group that with which some of us have quite a bit of experience because many patients come to us for treatment who are not qualified for cryoablation based upon the classic criteria.
So let's talk about the trials. What kind of evidence is there about the success of cryoablation so far?
So the first significant study that I mentioned, the study that I participated in 2009, was one that looked at patients that had tumors 2 centimeters or smaller, meeting the criteria that I just described, who underwent cryoablation, and then within 1 month of the cryoablation procedure, they underwent a lumpectomy or mastectomy to remove the area to see if the treatment was actually effective. And that initial study found that for tumors under 1.5 centimeters, the treatment was 100% effective at ablating the tumor. And for those that were between 50 millimeters and 20 millimeters, there were few cancers that were found, but not within the ablation zone, just outside of the ablation zone. So it really told us to take on measures that cryoablation works, but it's important to have high quality imaging so that you can be confident that the thing explains the extent of disease and that there aren't detectable areas of disease just beyond the area that you target. But specifically, it showed that if you can see an area well and target it, the cryoablation was 100% effective at killing the tumor. And that's what we wanted to see. Because of that, we were able to launch a number of additional trials, a trial called the Frost trial, a trial called the ICE3 trial, all looking at the use of cryoablation in people who did not require subsequent tumor removal. Tumors, again, were under 2 centimeters. They had cryoablation performed, and those patients have been followed to see what the long-term outcome of their treatments are. And we've recognized that the recurrence rate for those patients is only about 2% over 5 years, which is exactly what you get with a lumpectomy operation, 5 years. So again, it's proving that cryoablation is effective. It's effective at ablating tumors, and it's effective at preventing recurrences in the vast majority of patients, 98%, with 2% having recurrences primarily from disease that's outside of the cryoablation zone that was not seen early on, but that becomes detectable with ongoing follow-up. I think the challenge with cryoablation is that lumpectomy has been so successful for so many years in terms of preserving breasts and preventing cancer recurrences that if it's to be replaced, it has to be replaced by something that's really good. It's being held to a very high standard. And maybe the standard is a little too high because it limits options for women who may not want to have a lumpectomy, who might have a small breast that's even disfigured by a lumpectomy. But I think the bar has been raised. And so if we're having great results with lumpectomy, if we're going to substitute a new treatment for lumpectomy, it has to live up to the expectations that we get with lumpectomy. That's the main sort of cultural and political barrier to adopting it.
Are there any other treatments that people should be getting when they're getting the cryoablation? Can you just do the cryoablation alone, or do you have to do other treatments as well?
It depends on the circumstances. So we started with kind of the ideal patient for cryoablation, someone with a stage 1 tumor that's estrogen sensitive. So for most tumors that are estrogen sensitive, or in fact, all tumors that are estrogen sensitive, we generally recommend that a patient consider taking an anti-estrogen medication to reduce the risk of recurrence in the breast, but also to reduce the risk of recurrence of that cancer in other parts of the body. Cryoablation in that situation is being used as a substitute for surgery, but even when someone has surgery, we recommend medications to prevent recurrences in other parts of the body. The same principle applies for cryoablation. If someone has cryoablation and they have an estrogen-sensitive tumor, they're generally advised to take an anti-estrogen therapy to reduce the risk of recurrence. There also are people that have different kinds of tumors, and sometimes we treat patients with triple-negative tumors, which are not estrogen-sensitive, where there would otherwise be a recommendation for chemotherapy. Just because you've had cryoablation doesn't mean that chemotherapy isn't needed. So really the way to think of it is that cancer is generally what we call the multimodal therapy. We do surgery and we try to make it better by adding radiation, and we try to improve the results further by adding medications. Cryoablation replaces surgery. In many cases, it doesn't replace radiation, and in most cases, it doesn't replace medication. That medication is needed because medication is directed at preventing recurrences in other parts of the body. That said, in one of the trials that I mentioned, the ICE3 trial, most women only had cryoablation. Very few of them had radiation, and only about 60% of them had medication. And despite that, there was still only a 2% recurrence rate. So although we often add these additional measures to get a perfect result, even cryoablation alone for these very small tumors is very effective as a standalone treatment. And in fact, many of my patients come and they say, I'm willing to have cryoablation, but I'm not going to have radiation. I'm not going to have medication. And I say, we still should treat your tumor. So I'm willing to do cryoablation because that's the most important thing to do. Additional treatments are additive, but not more important than the primary treatment, which is to deal with the tumor directly. I think the most important thing, and the message that I would like people to leave here with, is that breast cancer treatment, as much as possible, should be patient-centered. And that factors in not just the characteristics of the tumor that I described, but what the patient is willing to tolerate. And so there is, to some degree, a negotiation. It's figuring out what fits an individual patient. And for some, it might be cryoablation and radiation and traditional medication. For some, it might be cryoablation alone and no additional medication or radiation. And others, it might be in the middle. We try to quantify the risk of recurrence. So some people have a high risk of recurrence, some people have a low risk of recurrence. Inform them of that risk so that they can incorporate that into how they want to manage their own health. ultimately, we have to respect their decision about how they want to be treated. And it's my goal as a cancer researcher to increase the number of options so that I have a treatment available for a given person who may want to have cryoablation. Some want to have mastectomy.
What about there's something to do with the body when it's cleaning up the cancer that it possibly could identify the DNA of the cancer and build immunity? Is that something? I don't really understand that or know too much about it, but I've heard about it.
We've heard about it. It's something that is under investigation. It's a phenomenon that does happen, and we're just trying to understand to what degree it happens with cryoablation. The term that you're referring to is called the abscopal effect, which refers to immunity that can be created when the body comes in to clean away the dead tumor cells. The immune system, in that process of doing so, has the ability to recognize cancer-associated proteins or cancer-associated DNA, so that if those substances are seen in the body elsewhere, the body would have developed a recognition or immunity to them that can potentially prevent them from recurring or growing elsewhere. And so in some way, it's an innate immune response that can develop in response to cleaning away a tumor. It's a phenomenon that doesn't really happen with surgery, where you cut out the tumor without allowing the body an extra opportunity to interact with the dead tumor cells, because the living tumor cells often are effective at keeping an immune system away. But once they're killed, the immune system can come in and clean them away, and in the process recognize unique characteristics of the cancer cell that might be useful in the future in terms of developing immunity to it. So we know that it happens. It happens in animal studies, which are kind of idealized circumstances. It happens to some degree in humans, although it's not clear if it happens consistently enough and that the response is strong enough that you can count on it as a substitute for radiation or medication. I say it may be a little bit added, but not enough by itself to prevent recurrence.
I wanted to ask you about insurance for people, but before we finish, I really want you to share how people can reach out to you and find out about I want you to talk about the clinical trial that you have.
Yes. Most of our conversation has been about invasive breast cancer, because invasive breast cancer is something that you can generally see fairly well by ultrasound. It tends to form a mass that you can target by ultrasound. Stage 0 breast cancer, or what we call DCIS or precancer, is much more difficult to see by ultrasound. And because of that, it was never considered appropriate for cryoablation, because we typically perform cryoablation under ultrasound guidance. However, that's changed. I have developed a clinical trial in which we're utilizing markers that are inserted next at the cancer site, markers that are ultrasound visible. So what we can do is create something that's not ultrasound visible to convert it to something that is ultrasound visible by placing this ultrasound marker, and then offer it to patients with DCIS cryoablation. Previously, these patients were not included in clinical trials. They were not offered cryoablation because their tumor was not ultrasound visible. This clinical trial is evaluating a method of making their cancer site ultrasound visible so that they can be offered cryoablation as well, just like the invasive cancer patients. So it simply involves insertion of a second marker at the cancer site. Most markers that are put in at the time of biopsy are not ultrasound visible, but there are special ones that are ultrasound visible. And so we arrange for that to be placed. And once we have a clear target, we can then do the same procedure that we can offer to any other patient with an ultrasound visible tumor. It's an office-based procedure. It's offered locally here in Glendale, California, which is in the community of Los Angeles. Patients just have to make one visit to participate in the trial if they live outside the area. We review them through telehealth visits. We review their images in advance. They go through a screening process. If they're elected if they qualify for the trial, we have them come to the city for one day. We have the marker placed. They have the cryoablation procedure performed, typically on the same day or the next day. And then they can return home the very following day. All follow-up visits can happen in their home community. We just need to get access to copies of the imaging studies and reports to know that they are having appropriate follow-up. The final thing with the trial is that we do require that every patient who participates in the trial undergo a second biopsy of the cryoablation site 6 months later. They have cryoablation today, for example, and then 6 months later, they have a needle biopsy of the cryoablation site to document that there's no remaining cancer present at the cancer site. And all patients that have participated in the trial so far who've undergone biopsy of the cryoablation site, they've had no cancer found at the cancer site 6 months later. So it validates the principle that cryoablation does work for DCS. You just have to target it accurately. And we utilize that ultrasound visible marker to help us target it. So if people are interested in knowing about that trial or about cryoablation in general, there are two ways they can access me through the internet. I have a website called cryoablation.com. So www.cryoablation, that's CRYOABLATION.com. And the other is my main website, which is drholmesmd.com, drholmesmd.com. And they can find out about cryoablation or the other innovations that I'm involved with, that I've been pioneering over the years. But cryoablation is the one that I'm focused on at the time. And I think that it's the one that we're at the precipice. I think the doors will open relatively soon, but for now, you really have to do some homework to find it. And I appreciate the opportunity that you've given women here today to learn more about it.
I know that you also can help people that may not qualify for the clinical trial, but they want to have a consultation with you anyway. Is that true?
Yes. The clinical trial that we're conducting currently is a clinical trial of DCIS patients, stage 0 breast cancer, as we call it. I've already completed a trial of invasive breast cancer. There may be future trials, but most patients that come are treated what's called off protocol. They don't qualify for an ongoing trial. There are very few trials in the country for cryoablation at the moment, but participation in the trial is not a requirement for accessing cryoablation. We do offer cryoablation to women who do not qualify for the trial. Unfortunately, the upside, the benefit of the trial is that it's offered at no cost to the patient. Patients that seek cryoablation outside the trial must pay for the procedure, but we have the ability to treat most of them if they're seeking an alternative to lumpectomy or a mastectomy, even if they have larger tumors. We have the technology, and most importantly, we have the experience of treating patients who did not find lumpectomy or mastectomy an acceptable option for them. Cryoablation is often the solution that can be utilized to achieve the same results.
Yeah, great. Yeah, so this is wonderful. So lots of options for us. Thank you so much. Is there anything we've missed or anything else you want to share?
I think the most important thing to know is that wherever you go for treatment, the tendency is for physicians to offer you options that they're familiar with, that they're comfortable with. And so wherever you go, lumpectomy and mastectomy will always be the two options that they will offer to manage breast cancer. But it requires a little extra work often to find that there are other options available. And ablation is an emerging technology for treating breast cancer, a non-operative technology that's equally effective for treating cancer in most cases. And so it's important, as you said, and as I've said previously, for patients to talk with their friends, talk with their colleagues, understand the options that are available. And if they're interested in exploring alternatives to what their surgeon is offering them, check out the website, check out your resources to learn about alternatives to lumpectomy and mastectomy, because they do exist, and cryoablation is the most prominent one amongst them.
I want to thank you so much for being here and again, sharing your vast wisdom with us, Doctor.
Thank you. Have a great day.
Okay, thank you so much. If you want to catch this show, be sure you can check our YouTube channel at Smart Women TV. And you can also go to wherever you get your podcasts for Smart Women Talk. And if you want to join our free community, just go to joinsmartwomen.com. Until our next show, go out and live with more purpose, passion, and prosperity. Smart Women Talk is brought to you by Smart Women's Empowerment, a 501c3 nonprofit project of United Charitable. Music by Bill Lucas from his album When It Rains. Available on Apple Music and Spotify. Catch us wherever you listen to your favorite podcast, and be sure to join our free community at joinsmartwomen.com to access all our free Smart Women resources.